Well, welcome to this evening's webinar, From Data to Practice, Crafting Effective Clinical Protocols and Partnerships for Gastroparesis Management. My name is Angela Buffington Johnson, and I will be your host and moderator. We hope this will be a very engaging webinar for you, and we will have time at the end for questions. So please utilize the chat feature to answer all of your, to ask all of your questions, and we will go ahead and make sure we have time at the end for those. So now it is my pleasure to introduce today's speakers, Dr. Camille, Thélin, and Bailey Blankenship from the University of South Florida. Dr. Thélin is an associate professor and gastroenterology fellowship director and the director of Women's Digestive Health. Bailey Blankenship is a nurse practitioner and part of the Division of Digestive Diseases and Nutrition. Together, they are part of the Neurogastroenterology and Motility Center at USF. So please join me in welcoming Dr. Thélin and Bailey.
Thank you, Angela. All right, so this is, like Angela introduced, myself and Dr. Thélin. We are who will be leading this webinar tonight. You're going to hear from myself first and then Dr. Thélin to follow. And like Angela said, we'll be here at the end for any questions. This is just our disclosure from Intera. This webinar is sponsored by them. So these are the topics that we're going to cover tonight. These are our objectives, why effective clinical protocols and partnerships are crucial in managing gastroparesis. One of the things that Dr. Thélin always likes to say is it takes a village with these patients. Understanding gastroparesis, what is gastroparesis, what are the symptoms, what's the pathophysiology behind this disease, and some of our current management strategies. And then Dr. Thélin is going to take over to walk you through partnerships in clinical practice, developing some of these clinical protocols, implementation, challenges, and then some feedback mechanisms for your group. So to start off, what is gastroparesis? Gastroparesis is defined by delayed gastric emptying on a 4-hour gastric emptying study in the absence of a mechanical obstruction. So that is the gold standard for diagnosis, the 4-hour gastric emptying study. And what we're looking for is greater than 10% retention of that standardized meal that your patient's given at that 4-hour mark. There are 5 cardinal symptoms of gastroparesis, which include nausea, vomiting, early satiety, bloating, and epigastric pain. But your patients might record multiple other associated symptoms like heartburn or GERD, dysphagia, lack of appetite. Of course, those all go along with the disease process as well. So gastroparesis is a long journey for these patients. On average, it typically takes about 5 years from the onset of patients having symptoms in order for them to have an actual diagnosis. After this long journey, only about half of patients receive pharmacologic treatment within those first 3 months. And in a survey of 1,400 patients, only 4% were satisfied with their treatment for gastroparesis. So that just goes on to outline how difficult of a disease process this is and how really we're kind of lacking in management strategy for these patients. So what are the potential reasons your patient might have gastroparesis? This is something that can be idiopathic, meaning we don't know what caused them to have this disease. This can be related to diabetes. This can be post-surgical. This can be post-viral. This can be related to neurologic conditions. This can be infiltrative, or this can be medicine-induced. This slide is just outlining correlation between gastric emptying and patients' symptoms. So all of this is to say, patients can have severely delayed gastric emptying on their gastric emptying study, and report that they actually have minimum symptoms. And then some patients, you'll see that their study is just above or borderline normal. They might have very low gastric retention on that gastric emptying study, but however, their symptoms are much greater in severity when we're looking at the GCSI. And so the GCSI, just to go back to that, because that's going to be outlined or used as a marker on multiple of these studies that we're going to look at, is their scoring of that gastroparesis cardinal symptom index, which is those 5 symptoms that we looked at a moment ago.
And the other thing about that slide, Bailey, if you can just go back for 1 second, I don't know if you were able to go backwards, is just the fact that the GES is a labile test. I mean, it's not the end all be all. It's an old test, and granted, we need a new one, and there are people working on that. But what the consortium saw over a 12-year study is that you can actually flip a portion of the patients that are gastroparetics flip into a negative test. So essentially, they have the same symptoms with a negative test, which is a functional dyspeptic, or what we're calling a functional dyspeptic now. And then vice versa, 37% of them will actually flip into a gastroparetic. So just keep that in mind if you get a negative test and you have a patient who continues to have very similar symptoms and you have a suspicion that this may be gastroparesis.
All right, so this slide goes over the ACG clinical guidelines for gastroparesis. What are those cardinal symptoms? What do we use for diagnosis? Of course, these patients need an EGD to rule out mechanical obstruction. They need that 4-hour gastric emptying study. And then what is first-line therapy, which is dietary modification, followed by pharmacologic treatment, followed by nutritional support, whether that be enteral, fairly parenteral, and then non-pharmacologic, or what we sometimes refer to as advanced therapy for gastroparesis. However, this isn't we don't look at this as a step 1, step 2, step 3. Necessarily, you're going to be doing a lot of these things all at the same time. You might be implementing dietary modification and some pharmacologic agents, and looking at potential advanced therapies for the patient all at the same time. So these are more kind of building blocks. So now we'll go into what is management with advanced therapy. So there's,
all right. Oh, I'm sorry. Go ahead, Bailey.
Okay. There's a few different options here. One being Entera. So that is who this program is sponsored by tonight. Second being surgical options. So whether it be laparoscopic myotomy, or GPOM, so gastric pearl endoscopic myotomy, or Botox injection to the pylorus. And what is not here, but also sort of is similar and falls under really the same category as Botox, is pyloric dilation for these patients. So again, what are surgical options? Balloon dilation of the pylorus. Typically when Dr. Thélin is doing this, she'll dilate using a through the scope balloon up to 20 millimeters. Botox injection to the pylorus. I will say in our practice, we sort of use these 2 techniques as temporizing measures to see, is this patient someone who would respond to, a pyloric intervention, something to help the stomach empty better. GPOM, which again, endoscopic myotomy of the pylorus, or surgical pyloroplasty. It is important to note that Botox is not recommended as first-line therapy unless other adjuncts are used and trialed and failed first. However, again, there are certain patient populations who do respond really well to manipulation of the pylorus. And then important to note, some people are looking at the use of EndoFlip to look at distensibility of the pylorus, to also use that as an indicator of would this patient respond well to a pyloric intervention. So this is a meta-analysis looking at the use of GPOM for refractory gastroparesis. So this was looking at 10 studies, 3 prospective, 7 retrospective, combination of patients who have diabetic, idiopathic, post-surgical, among other etiologies. And what it looked at was the clinical success of GPOM after 1 year, which was about 61%. Unfortunately, a little bit lower than what had previously been reported. So now we'll look at what is Entera therapy and what are the components of the device. So Entera uses electrodes that are placed 10 centimeters from the pylorus along the greater curvature of the stomach. These electrodes are placed 1 centimeter apart, parallel to one another, and secured to the stomach. The entire length of the 1 centimeter electrode should be completely within the stomach muscle layer. And then of course, endoscopy is done after placement of these electrodes to ensure that they're not exposed on the mucosal surface of the stomach. Typically takes about 1 to 2 hours. Patients are under general anesthesia, typically an outpatient procedure, minimally invasive, and this is done either laparoscopically or robotically. Looking at selection criteria for these patients, they should have had symptomatic gastroparesis for greater than 1 year. This needs to be documented based on a 4-hour solid phase gastric emptying study. Some institutions do still use a 2-hour study, and so for that, you would be looking at greater than 60% retention versus, of course, like we said at the beginning, the gold standard, which is the 4-hour gastric emptying study, looking for greater than 10% retention at 4 hours. These are patients who have failed dietary modifications. They're refractory or intolerant to antiemetics and prokinetic medications. They are a viable surgical candidate, so they're fit to undergo, a minimally invasive surgical procedure, and approved for patients who are ages 18 to 70 years old. Patients who would not be a good candidate for Entera are patients who are on narcotics, patients who are suspected to have more of a psychogenic vomiting disorder, of course, patients who are not stable enough to undergo a surgery, and other physical or mental health conditions should be considered for these patients. This study looked at patients who have idiopathic, diabetic, and post-surgical gastroparesis. This study looked at only patients who had their Entera device turned on, and then looked at 1 and 5 years following a device adjustment. Also used the GCSI. What this study found was that at a 1-year follow-up, the GCSI total had diminished drastically from an average of 3.7 down to 1.3 at a 1-year follow-up, and remained stable at 5 years at 1.4. And then also when we're looking at the nausea, vomiting in these patients, that's where we saw a drastic reduction from an average score of 3.5 down to an average of 1.3 to 1.5. Also looked at our other cardinal symptoms or symptoms, including abdominal fullness, early satiety, loss of appetite, bloating, abdominal distension. And as you can see, these patients on average all saw significant improvement that lasted beyond that 1 year into that 5-year follow-up. This study also looked at hospitalizations in our patients with gastroparesis. Again, significant reduction. Preoperatively, about 58% of these patients had been hospitalized for their gastroparesis within the past year prior to having their device implanted. And that went down drastically to 12.5 or 14.5 at a 1 and 5 year follow-up. Okay, So you've mastered diagnosis and sort of what our treatment options are. And so now we're going to move on to talk about clinical practice.
Yes. So you've accurately diagnosed gastroparesis, you're following the guidelines, you've got an algorithm, you're essentially trying everything. I like to say you throw the spaghetti at the wall with these patients, even though there is an algorithm. And even though certain things like Bailey mentioned, Botox is not currently recommended, you'll find that most centers and most specialists will do what they can. Now, the one thing that we just caution about with Botox is that our surgeons and our advanced endoscopists will tell you that it feels a little bit like it's glued together, the mucosa, submucosa, if you've got a patient who's had multiple Botox trials. So just keep that in mind. But EndoFlip is a great tool, like Bailey was saying. You're on the treatment algorithm, you're passionate about caring for this patient population. And so now it's a time to talk about what the basics of this webinar is about, is how to support these patients and how to essentially try to figure out what best to do for them in your clinic or hospital space. Like Bailey mentioned, the journey for a gastroparetic is complex, and it takes about 5 years for these patients to get a formal diagnosis. You know, a lot of patients get turned away. It's very challenging. They'll hop in and out of EDs. There's all sorts of messages on message boards about patients feeling really down and out because they're misunderstood, not only by medical providers, but also their family. And so it just can be very difficult for these patients, and they bounce in and out of the hospital systems. And what we want to do and what we want to offer you here is essentially a comprehensive program to sort of think about how to approach these patients. Now, I said this the other day to someone that was in clinic with us. You know, the days of treating patients in a silo are long gone. As we live longer, as we live and have more medical and surgical options for how to extend life, you know, we have to think about multidisciplinary care because medicine keeps getting more complex. And so this is essentially where we're going. We're talking about a multidisciplinary approach, which you can do either when you're in a center or not, and just establishing a community of providers that will help you to care for these patients. So what is this multidisciplinary team that is your village to help you to take care of these patients? So it includes providers, MDs, DOs, APPs, but also think about your GI surgeons, right? So a lot of centers may not have advanced endoscopists, or if they do, they may be centers where the advanced endoscopists are not trained in third space, or they may be centers where those advanced endoscopists are taking care of transplant patients with biliary strictures, or are really busy doing other kinds of techniques and other therapeutics. So you should think about, if you've got a group that may be in your GI practice, think about your GI surgeon as your partner. At our Neurogastromotility Center at USF, actually, my co-founder and co-director is Dr. Suika, who is a GI surgeon. He's a foregut trained surgeon. And we do have advanced endoscopists, but we are also a transplant center. And so our advanced endoscopists are very busy doing other things. So remember to think outside the box and to include your surgical colleagues, of which we know we have a lot today on the webinar. And we welcome everybody here because, like I said, it takes a village. You want to think about someone that's got, you know, some expertise in the GI tract for chronic illness when it comes to dietary and nutrition care. It does not have to be somebody who is an expert in gastroparesis. You know, a lot of the information is actually rather simple. You want to have a very soft kind of diet, something that's mimicking the 2 millimeters cube that your stomach is essentially providing and doing for the food, right? It's a blender and it's filling itself with acid and it makes this chyme, this 2 millimeter cube. So you want to do something that's small particle, low fat, low fiber. And so you don't have to specifically wait for somebody who is GI trained. You do need somebody who has got some expertise in chronic disease though, okay? Behavioral health is very important. A lot of these patients, like we said, it's been can be a tremendous length of time before they get cared for. And that will put a tax on someone's psychological and mental health, and also the distress of how much this affects their quality of life. And, even though you may have a really strong support system at home, it's like anything else. Sometimes people get a little tired about hearing, even in our very small circles, like in our family, chronic illness is a very difficult thing because you live in your own little world of pain and nausea. And even though you can have that support system, sometimes people need to focus on other things. So behavioral health is something that you want to focus on. You want to make sure to get your patients. You also want to have access to radiology. It doesn't have to be in-house. You need a gastric emptying study, even though we talked about how this test is not infallible and how you can have a switch, and depending on how patients are feeling, you still need something that's going to help you to determine. Now, it doesn't have to be a GS. It could be an upper GI, small bowel follow through. There's other types of tests that we can look at when it comes to that. And then obviously you need an endoscopy. Staff are really important. You're going to need to think about nurses and MAs and maybe schedulers and prior auth specialists for certain specific types of drugs that might be a little bit more difficult to obtain, and a nurse navigator. Now, this is not to say that you have to assemble all these people at once. Our personal experience and mine is I've been at USF for 5 years, and it's taken us 5 years to get here, and it's always an ever-changing thing, and we're always constantly reevaluating. But what's lovely is that every year, every 6 months, when we sit down, there's more and more people sitting at the table bringing their ideas, and that's what you want. You just want to build that community slowly, and you'll find people who are interested in helping this patient population. GI motility nurses are a treasure, like Bailey. Nurse practitioners that are interested in motility are few and far between. And again, I say that this is a really lovely community, both providers when it comes to nurse practitioners, APPs, and MDs and DOs are a type of person that really reflects on how they can help the patient and really have a different approach, but also to each other. There's no competition. We love to share ideas. And we were just talking about ANMS, American Neurogastromotility Society, and what a lovely experience it is to go to a conference like that, or GAP, for nurse practitioners, and just gaining ideas and networking and making those connections. And then you want to factor in time when you're thinking about all of these people, because you want to make sure that they're going to be trained, and you're going to need to think about, how do you do the breath tests and the myoelectrical activity tools and the manometry, and how do you answer phones for this patient population. This is our team. I mentioned Joe, Dr. Suika, and you've met Bailey. We also have Dr. Clam, who is actually our section chief for the Department of Psychology at Tampa General Hospital, which is our academic hospital in Tampa. And we co-work at Tampa General and obviously University of South Florida. And we also just recently rehired a lead dietitian, lead nutrition specialist, Kelly Haliwa, who is with us. And so we're very fortunate. But again, this didn't just happen overnight. It's been an evolution, to be honest. What we look for, and again, in your community or in your practice, GI surgeons, psychologists, and dietitians, and then that's the who, right? When you get that, or you start to assemble that team, you want to think about the what and the why. What's the mission of your group? And you want to think about the brand. And yes, the brand is whatever the mission and the brand of your hospital system, but you can even subspecialize, right? We thought about what we wanted for our team. We wanted to make it accessible. We do webinars, and obviously we're really happy to pair with Entera and to be part of their faculty, because they're an amazing company to take care of these patients. But you want to think about the community as well too, and how they're going to respond. So think about social media and advertising and marketing teams that are at your hospital system or at your university or maybe in your practice to get your message out. So we went over the who's in your village, the what and the why, which is really your brand, your mission, and how you get, and obviously The why is the patient, right? It's a patient-centric model, but the how is what you're going to do with the workflow for this chronic care. When you take care of this type of patient, it's a chronic illness. And that's something that you have to teach yourself. You have to teach the patient. You have to teach your staff, your MAs, your nurses. These are not patients that are going to be a one and done. These are patients that are going to have questions, that are going to come back, they're going to have flares, etc. So you want to think about structuring your clinic in a way that hopefully will allow you to see enough new patients to help in your area. We've decided that we sort of pair off on follow-up visits, and I will see a lot of the new patients, and then Bailey really helps out because she's got more clinics time than I do when I'm on the inpatient or I'm scoping. Then she has clinic time to be able to see those follow-ups. So maybe thinking about an APP to see the majority of your follow-ups to really help you to be able to expose the community to your practice and your help and guiding them as far as what the next step is. You want to think about whatever electronic medical system you have, speaking to your analyst teams and your clinic managers about what your decision tree management looks like. So most clinics have a decision tree, and this is something that I've learned along the process, and you see ours right up here. Essentially, when a referral comes in, there's going to be a lot of clicks that get clicked, and a patient's going to work their way down a decision tree to figure out who they go see. And under each one of these appropriate diagnoses for motility, as you see right there, if you click on anal rectal manometry or anorexia or bloating or gastroparesis, etc., it actually will pop up and tell you which providers are available. And then from there, your schedulers will put the patients in the clinics. So this is something that I, didn't know a lot about on the back end. And we're still refining this and trying to figure out and make sure that the majority of our practice also understands that 60% of GI is really kind of chronic management, IBS and disorders of brain gut, and that we don't own this entire patient population, but 30% of what we do, 30% of what they see should be something like that, because 60% of those patients are going to kind of filter out throughout the entirety of your practice. And then you want to think about whether or not your institution allows patients to make their own appointments. In this patient population, I would caution that, just because, again, there can be some catastrophizing that happens, and then you may find yourself having slots that are filled with patients that may have just recently seen you and may not have actually put into practice what you just recommended. Communication is key. Again, we talk about, I just kind of mentioned this, like chronic care, catastrophizing, flares, things that can happen. You want to be generous with this patient population, but you want to set an expectation. Chronic care is not one and done. And that's also something to teach your staff, right? We've gone through a lot of iterations of who is actually involved in our clinic and helps us from a medical assistant standpoint and an RN standpoint, just because you really do have to have a different approach. It's important to educate the patient on when to call versus, when to message or when to wait for an appointment. And maybe think about using artificial intelligence if your electronic medical record system has this available to you to kind of help you put together some care pathways. And here we have the model that we share from Entera, which is a lovely care pathway. And we do a lot of this essentially in, first-line therapies and pharmacologic and dietary modifications in that first visit, and then reevaluation in that follow-up, and just letting the patient know that this is how we work and we operate. We also make sure that we have an electronic medical record that has parameters set for very clear and concise communication. We've certainly had to tell patients, but USF and Tampa General have made this a general rule that my chart messaging is limited to 500 characters to encourage a very concise, to the point message. And we again educate the patient that this is not an urgent or emergent medium type, but you'll still have people who, kind of slide through the cracks, but it's just about being patient and generous with this population. developing a clinical protocol once you've set up, you know, your who, your what, your why, your how, and thinking on this process. You want to think about the methodology of what that practice will look like. And we are actually on our second iteration of what this looks like. So initially we were accepting all patients and sort of inheriting patients, just because a lot of the community would get to a point where they weren't exactly sure what to do with their gastroparetic patients or their functional dyspeptics or other types of dysmotility of the GI tract. We've realized that, you know, with the fact that we are getting better at teasing out and figuring out who has what, right? Our diagnostic tools are getting better, and we as clinicians are getting better at sussing out who has these diseases, even though it does overall take a very long time for a diagnosis to appear. But we hope as we do more things like that, that will change. We realized that that type of longitudinal care was very difficult because we would only be able to help a very handful, and it would become an a finite thing and not an infinite supply. So we are in the second iteration. Like I said, we are, we've met with a lot of our groups, our division leaders, our Department of Internal Medicine. You'll want to meet with your hospital C-suite, et cetera. This is who you talk to about what the practice may evolve into if it's a very popular practice, and you want to be able to help the majority of your community. And so you may have to change the way that the methodology of that. So what I mean by this is that originally we would see patients inherit them, and they would essentially graduate from their community care physician. However, because of the fact that we're getting more and more referrals and unable to see patients in a very quick time, we're having to think about now, okay, this is really and again, it's a family even across, you know, the state, or across to another state, or across to St. Pete from Tampa, right? So we want to think about being a family of gastroenterology providers who care for these patients and have maybe a primary GI physician and then a consultant motility physician to really help. And this is not to say that anyone is just saying, okay, go over here or go over there. It's really meant to be a helping hand across. And so everyone is to work together. That's really what we would love to like create in our state. So our consultant service, your consultant service is what we have here. I do think motility care is a lot about a consulting service because longitudinally you will be very taxed. You will be very popular. Identifying the objectives are important. You know, who are those patients? Are you simply a gastroparetic dysmotility provider? Do you take SIPO, chronic intestinal pseudo-obstruction? Do you also manage chronic constipation? You know, thinking about the broad span of dysmotility, where are they coming from? You know, your institution actually can create a heat map to tell you where patients are coming from, to let you know how far patients are traveling. And again, thinking about that patient who's already got a very difficult quality of life, if they're across the state or in a different state or a different region, you know, it doesn't make any sense for that patient to keep driving back and forth to come to see you. You really need to have a co-community with that local provider. Who are those referring providers? Maybe taking the time and doing webinars or symposiums. Our institution does symposiums on the East and the West Coast, and really just kind of letting community providers know what we offer at our academic institution. And I think that, you know, going to these places and going to these symposiums, if you're in the community, actually helps you to do that networking that we talked about, and, you know, allows you to introduce yourself, and you'll find that it is a very warm population of providers. Our referral sheet is right here. This is just ours, and it's the first iteration of this. And I promise you, I'm sure it will go over a couple more, but we are essentially a consulting service. Given that we're an academic center, we do serve as a tertiary and quaternary referral center because we can't handle that longitudinal care model. Equipments and compliance, other things to consider is you're going to need certain types of equipment, right? And so you're going to have to meet with your administration, whether it's division managers or the chief or the Department of Medicine and their division administrators to discuss funding. And you're going to have to figure out when that budget cycle is and when you can put in an ask, and whether that ask will actually be able to get cycled through when they pass the next budget. So being thoughtful about these things. If you work with for example, I do anal rectal manometry. We have a program in our clinic for anal rectal manometry. We only have 2 catheters, but our academic institution, actually our hospital, used to provide inpatient. We don't do inpatient anymore. There are 3 catheters that have depreciated in age, but not in wear because they haven't been used. And so can we buy those essentially from TGH? Well, we found out we don't even have to buy them. We just have to transfer them. So, getting creative and thinking outside the box is really helpful in these situations. And getting to know your admin team is very helpful. Funding sources: is there a service line? Is there an endowment? Is there a division fund? Or is there philanthropy for your practice? That might be a way to look at something. If you're in an academic practice, maybe thinking about participating in clinical trials is very, very helpful as far as being able to get patients care. We're currently participating in the Navigate trial with Intera with Dr. Suika. And then training, you want to, again, like I said, account for the training time for all those involved staff. Compliance. A lot of this stuff, if there's cleaning required, you may have to work with your medical health administrators on protocols. I've learned how to write a standard operating procedure protocol, and there's all sorts of disinfection practices or instructions that may be involved in certain things, and your physician services educators. And there are people, and I've learned about all of these people, and again, it's taken years, can assist you in helping doing these things. And then location: where are you going to do these procedures? Is it in a clinic or an endoscopy suite? If there's ways for you to recapture that, whether it's from a monetary standpoint or an RVU standpoint, you want to think about that as well, because most practices these days, and even academic institutions, unfortunately have moved for fee for service. And so you want to be cognizant of how much time you're taking to be able to care for these patients, but also to be able to care for yourself and your family and whoever gets the downstream effect of you having this lovely career. And then partnership, this is kind of making sure that you understand that you're going to be a very valuable person. So I've said that you're going to have to sort of go front and center and talk to a lot of people that you maybe have not thought that you're up to snuff to do just yet, but you are actually a very, very valuable member. You generate a very big downstream revenue source for all your referrals, whether it be your foregut surgeon or whether you've got a concomitant chronic constipation that has a pelvic outlet issue and you need your colorectal team. Your gynecology is a team that we work with a lot: radiology, the body image radiologist, advanced endoscopy, bariatrics. So really identifying who those key partners are in your area, in your practice, in your institution, and getting to know them. You've got to introduce yourself and let them know kind of what the model is of this structure of this clinic that you're building. And, it's a patient of one, it's an N of one, and it will slowly happen and people will know who to refer to. Make sure that your radiologists do understand the standardizing protocols for GES. I do not recommend a 2-hour. In fact, 2 hours out, don't do 2 hour, never do 2 hour, 4 hours. And then get to know your Intera reps. And we actually saw that most of you know who your Intera reps are, because I saw on the spreadsheet that everybody knew who that person was in their community. So that's wonderful. And then build inpatient partnerships. If you're a community physician and you have a hospital system, but there's a hospital team that takes care of those patients, get to know who those people are when they're going to be admitted for flares and establish the relationships with the hospitalist and the ED providers to really ensure that you have this coordinated, informed care. I like to joke that I give my cell phone out like candy. I don't give it to patients, but I do think that it's very important for my co-colleagues to have access to me. And I'll tell you, we have a lot of patients that are admitted, but I don't ever really feel like it's a burden for people to call me or send me a message on secure chat or something like that. And then, you know, if your services are not in-house, then where are you going to refer to, and where's the necessary co-management? It might not be in your system. It might be in a down the street system that might not be yours, but you might want to think again in that coalescing village of how do I best take care of that patient? So think outside the box. And then get to know your codes. Like once you're established and you're doing this, you really need to be able to figure out how to bill appropriately and stay on top of the changes. And Tara's wonderful about helping put together a coding and payment guide. They have webinars that will teach you about all the updates that CMS or Medicare or Medicaid will have. Like for example, and you want to know what your ICD-10 codes and your procedure codes and your CPT and all of that is important. It's ever changing. There are people who make full jobs out of this. So I don't expect anyone to be an expert, and I certainly am not. But I do think that it's very important to at least know where you can get the information and knowing where that resource is. And then finally, understanding the paradigm of your institution. Are you a claim or a fee for service? Do you work on an RVU or a measuring value? You know, what's your volume of new visits versus follow-up visits that your institution is looking for you to hit as far as a goal? And if that's the case, again, remember your value. You might not have an NP yet, or you might not have a PA, but you're going to be able to give something to your community that has been lacking. And so you actually have this big block to stand on, and you can show that when you look back and you're coding correctly and you say, hey, can you pull over the last 3 to 6 months, how many patients with these ICD-10 codes of gastroparesis, chronic nausea, vomiting, functional dyspepsia I've seen, to show what you're doing for the hospital system. And yeah, that's all I have to say about that for reimbursement. And then challenges, you know, are to be expected. I mean, again, you're not going to get this immediately right off the bat. Clinic spaces can be sparse. You want to assess your availability and alignment. Your institutional goals originally might not, you know, align with yours. You want to make sure that you're in a health system that has priorities that match yours. And you may find that as you evolve in your career, this may be a moment where you actually go somewhere different. And I'm not saying that people should do that. I'm just saying that, you know, there is an evolution to how we think, and change is inevitable no matter what we do. Team composition is something you need to think about. While you may have a steady GI surgeon, and APP, you know, there is a gig economy that recently has been very impactful as far as like onboarding and support strategies. So especially in the dynamic staffing arena, like the nursing navigators, the MA, the schedulers, you might be working with people that you develop an intimate relationship and they may be gone. And so having a little bit of an understanding so that you can fill the gap in between is very important. And then going back to your division and saying, or your boss, this person has left, but do you know how important I am to this practice? And we need to make sure that we're hiring for this position that has now become vacant. Patient provider boundaries, again, setting that expectation early and making sure that you have communication norms with that patient. Leadership collaboration, I've mentioned that multiple times. You've got to engage your chief medical quality officers, compliance, privacy, billing, coding, revenue. These will come all little bit by little. It's a trickle effect. It's not all at once. And people who are in positions above you may take care of a lot of this stuff, but it's good for you to know the business behind the scenes so that you can understand how valuable you are to these institutions. Your referral management, making sure that, you know, you speak to your colleagues. You're not a catch-all for every inappropriate referral, and the same thing about your EMR. And then your reimbursement is really important, and we talked about that. So in summary, operational foundations, making sure you have your clinic space aligning with your institutional goals, making sure you're thinking about a multidisciplinary team over time, planning for staff turnover. So knowing a little bit about different areas and arenas of how to make this whole system kind of keep chugging along is really important. Setting that patient provider boundary is important to you as well, and your health and your wellness. Collaboration, I mean, I've just said this over and over. It just takes a village, and I don't have to read all that to you again. billing and financials, making sure that you understand that eventually at the end of the day, everything is a code. And you love your note, we love your notes, we love our notes, but at the end of the day, it really does come down to codes, and that's how claims get processed. So make sure that you're coding appropriately for the work that you're doing, and you can put time on there with those patients. Making sure that you're using your marketing and your outreach, and there's all sorts of the days of social media has really enhance the way that we communicate with one another, and things like this, right? The world of Zoom and webinars have really changed the way we communicate. And then finally, just making sure that you're constantly looking at data about how you're doing, how things are going, sitting down and really identifying opportunities for you to grow, identifying opportunities to bring on new people into your team that are excited about helping you do that, and really leaning on them and leaning on their expertise. And then just reassessing that workflow constantly. We always find things that are working or not working, and then we just make a decision about who's going to take care of what, and then just move forward. Be generous to yourself, be generous to the gastroparetic patients. They've faced a complex, frustrating journey. So meet them with empathy and patience and flexibility. And then don't forget your wellness. Caring for this high patient need population is taxing. So make sure that you're prioritizing your boundaries, your support, and your self-care. That's it.
Well, thank you so much, Dr. Thélin and Bailey. I appreciate hearing your practical knowledge and advice. I know we do have some questions in the chat, so let me go ahead and jump over. All right, the first question here, Dr. Thélin and Bailey, what recommendations do you have for centers that lack certain multidisciplinary team members, such as dietitians or behavioral health specialists, to ensure that comprehensive patient care?
Bailey, you want to take the dietitian one?
Yeah, so something that we often use is a website. It's called Use Nourish. Nourish. It's something that you can send your patients. It's something that if you reach out to the company, they'll send you brochures that you can pass out. But it is an online nutrition service. They accept most insurance companies. So if your patient has, an insurance plan that covers them seeing a dietitian, that can be helpful. Something that we used when we had a gap where we didn't have a nutritionist as part of our practice for several months. And I think a lot of our patients, found it beneficial.
Yeah, we had a gap from October to just this month, just like last week, really, honestly. So we have just been sending patients there, and there are other dietary, international, like telehealth. So essentially you're sending them to telehealth. Psychology Today is a really great resource for behavioral health. You can type in states and zip codes, and it will take you to a drop down. It'll show you how many providers are in that area. It specializes what they do. Are they good at chronic illnesses? Do they manage grieving? Do they manage, anxiety and depression or loss or whatever it might be? So that can be a good resource for patients, for psychology, licensed social workers, therapists. Same thing for hypnotherapy, acupuncture. And guys, we make like a Rolodex. Like we find out things, and we have a little area, and we were just cleaning it up the other day, and we just save a business card and get to know that person and really establish that network of that web of taking care of patients.
Perfect. Thank you. All right, this next question. Enterotherapy is indicated specifically for the treatment of nausea and vomiting associated with gastroparesis caused by diabetes and unknown origin. However, our next question in the chat is, what is your approach on treatment of patients who have classic symptoms of gastroparesis, but non-delayed gastric emptying? So Dr. Thélin, while enterotherapy is not indicated for non-gastroparetics, I'm hoping you can answer this question with your personal approach.
Yeah, so my personal approach is first to remind you that the long-standing 12-year NIH consortium study that looked at almost like 9,000 patients really shows you that the GES is not an infallible test, and that Again, 47% of patients will flip into FD, and vice versa, 37 will flip into gastroparesis. So you're capturing them potentially at a moment where they had an emptying that was okay, or vice versa. So I would tell you that the approach remains very similar. There are also, and I kind of briefly mentioned this, there are clinical trials that are looking at the extension of gastric stimulation, electrical stimulation, in patient populations that are not fitting the classic gastroparesis based on this very old study, which is the gastric emptying study. So just keep that in mind, that there is an evolution. And if you listen to the majority of the experts and a lot of what's being published, is that this is a spectrum, and that what we are calling functional dyspepsia today based on Rome 4 may be different in Rome 5 that's about to come out, and maybe different in Rome 6. And so we have to think a little more holistically and saying this patient is responding or has very similar phenotype as a person who has a positive test. I'm going to approach the patient very similarly.
Okay, thank you for sharing that approach. We do have a question around what GPOM is like after a patient has had Botox. Is it harder? And have you seen any differences in the outcomes for the patients?
Yes. So I think I briefly mentioned this. Dr. Sweeka likens it to super glue. He's like, oh, thanks. You super glued the mucosa and the submucosa, and I can't get to what I need to get to. So we have in our institution, we have really just deviated away from Botox, and we are doing pyloric dilations as this sort of gap to decide who's doing well and who would benefit from a GPOM and or a dual placement with Intera. So we're really sort of, we're deviating away from Botox. I will tell you today, though, on an inpatient, we did talk about Botoxing a patient because he is sort of like the patient that you presented earlier. I think falls in the functional dyspepsia, doesn't have a positive gastric emptying study, but I really want to see if this is somebody who we need to be thinking about being a little more interventional surgically, because we have failed all of our other therapeutics. So yes, the answer is it's going to be very difficult to separate out those muscle fibers, and those muscle fibers are going to be very, very coagulated together from that Botox. The other thing is, and this is more so in the dermatology world for people who are getting Botox every 3 months, but there is such a thing as developing antibodies to, and again, Botox is actually just a brand name, but regardless, there are other types of botulinum toxins that we can inject. And there are antibodies that can be made to this. So sometimes that evolution is actually that someone is developing a resistance. So just keep that in mind. That's not really something that's been looked at very much in the GI population, because again, we've sort of flipped. Another thing you could think of if you have endoflip, who'd be really a good candidate for Botox or GPOM would be if somebody's got, like Bailey mentioned, a decreased distensibility of that pylorus. And so really, essentially, they've got pyloric spasms there, and they're going to be somebody who's going to benefit from you creating that different pressure gradient from high to low.
Okay, insightful. Thank you. All right, Dr. Thélin, you talked about the role APPs play in your workflow. Can you and Bailey please both share how you've built out that relationship, and then the capabilities at USF and how it can be beneficial from a workflow standpoint and to the patients?
So I'll just briefly kind of summarize what I said originally, and then I'll let Bailey jump in. But I tend to see a lot of the new patients and just kind of set them on their way. These are patients, again, we're tertiary referral coordinary. So I see people who have seen many gastroenterologists. And sometimes I see people, and I think I said this last week and Tara in Dallas, that I see people who have seen, the gurus like Dr. Brian Lacey, and then they come to me and I'm like, what am I going to do? But, sometimes I just have to reaffirm that what we're doing is for the right reason. So I'll see that new patient and get them on their way, and then I'll need to go somewhere else because I'm also program director. And so that patient now gets to see Bailey because she's got more clinics during the week for follow-up.
And Bailey?
Yeah. I think one thing that's been really beneficial is we actually share a clinic on Monday mornings where we see patients together. And so for a lot of these new patients, I think that of course, they believe they're coming here to see Dr. Thélin, and who wouldn't want to see Dr. Thélin and follow up with her all the time. But that's something that has helped, that her and I have a very close relationship. The patients can see that when they meet both of us for the first time together in clinic. And so that often kind of eases some of their anxiety, where they're not feeling like they're just being passed or punted,
Yeah.
like they often are, where, no, it's not that Dr. Thélin doesn't want to see me. It's like she said, she just doesn't have the physical capability to follow these patients longitudinally forever. We'd love to clone her, but we can't. And so I'm really there as the next best thing. And because we have such a close relationship, I have no problem, and the patients know this. I'll sit in clinic and I'll call her, or I'll text her. We'll get her on the phone, just for even a brief, 2 minutes to run something by her. And I think that's been really beneficial.
Yeah, and we actually are petitioning to try to be all together. So 3 of us on Monday afternoon are in the same, we call it the bullpen. So we're in the same bullpen. And so if I need something from Dr. Suika, or if I know this is a patient who has failed dietary and prokinetic and antiemetic therapy, and I know this patient needs an Intera placement, I know this person needs a surgical intervention, I'm just going to ask Joe and talk to his MA and say, guys, can you just quickly come in and see this patient? Bailey is really useful as well too, in the sense of follow-up patients for interrogating pacers. So we just tried to pair off and be really thoughtful about how to work up to your level of practice, and making sure that we all realize that we're not an infinite resource. And that goes for all of us. And the same thing, making sure to set communication tones on EMR, and helping the patient understand, like, this is your follow-up on this day. But if you send a message, it'll be me and or Bailey talking to you, letting you know. And we're a very interactive group.
I witnessed that this last weekend at the Intera course, where you and Dr. Suika were able to really talk about that partnership. And it was a great, and you did mention as well about having him be able to pop in and meet a patient. So that's great. All right, I think we have time for just a couple more questions. I have one here. So we have a question as to whether Intera is approved for gastroparesis-like syndrome, or for those who have a normal gastric emptying study. So just again, Intera therapy is indicated specifically for the treatment of nausea and vomiting associated with gastroparesis caused by diabetes or an unknown origin. It is not approved for gastroparesis-like symptoms or syndrome, or those with a normal gastric emptying test. So just wanted to make sure to touch on that question.
And the same thing that we said before, clinical trials, guys, clinicaltrials.gov. Things are happening around us.
All right, and we have a question regarding your personal approach when choosing which advanced therapy to use and when. So what patients do you start with Intera first versus GPOM first, or GPOM plus Intera from the start? Tell me about your patient selection for surgical management.
Wow, that's a doozy.
That's the question, right?
So, okay, I'll give you one example. I've got a diabetic who is in and out of the hospital, and he is insulin dependent, keeps going into DKA, hypoglycemic. After that, can't take his insulin because he's hypoglycemic, because he can't eat. So now we're in a chicken egg situation. Okay, you could keep helping that patient. I say helping by saying, you got to go see your PCP, you need to go get your endocrinologist, needs to make sure that you're monitoring your insulin a lot better and your hyperglycemia, blah, blah, blah. But this is a person who has shown you over and over that they are in this catch-22. And so in that situation, I would say this is someone who needs medical, dietary, endocrine, and an Intera. And probably, because the studies are showing that dual therapy is actually really helpful, I would do a GPOM on this person as well too. If I have a patient who has metabolic syndrome, is a probably a candidate for a bariatric surgery. In that patient, I probably would tell you, especially if I had a patient like this, 40 years old, had a cardiac arrest, or 40 years old, had a stroke. I would tell you that this is a patient who likely needs a bariatric surgery. I would actually skip over medicine and a lot of the other things and just skip right to bariatrics, right? I actually would. If this is a patient who has failed prokinetic and failed antiemetic therapy and falls within the current guidelines, I would suggest Intera. We actually do a combination of Intera and GPOM on most of our patients these days, because the studies are showing that the long-term effect for these patients is better than the single effect for the dual combo.
And I would add, a lot of it's based on symptoms. So if the patient is not nausea, vomiting predominant, they might not see much benefit with a gastric stimulator. And so really what's driving their symptoms, and that's something that we try to make very clear in, our documentation. This is a patient with diabetic gastroparesis who is predominantly, pain, or predominantly nausea, vomiting. What's their kind of phenotype within this disease?
Mm-hmm. Using the phenotype is very helpful for you to try to differentiate what's the therapeutics that you're going to need to apply.
Okay, thank you. All right, we have time for just one more question. We have a question from a fellow about to start practice in a motility faculty role. What would you recommend as far as timing for new patient appointment slots and then follow-up slots? Any other tips?
So I'll say that if you're in academia, your slots are most likely going to be 30-minute slots. And most places will still allow you to do 30-minute slots for both NPV and EPV. You may find yourself in a situation where you could ask for 30 for new and 15 for EPV. But I'll tell you that, again, this is a patient population that needs a lot of repeating, a lot of re-education, and I would be wary of the 15-minute slot. I would really make sure that you understand what your paradigm is at your institution, whether you're an RVU or you're not. You've got to figure that out. And then I'll just tell you what I do, which isn't really what everyone else does, which is, so I'm also the program director, so I just don't have a lot of time. And I'm building our anal rectal manometry team as well too. So I just overbook people. But I also have the luxury of working in a group where I've got fellows and there's residents and there's Bailey. And so, we're popping in and out of rooms and I'm talking from 7 to 7 basically, but it allows me to see a huge amount of patients. So I'll double book on the hour and then 30 minutes and then double book on the hour and then a 30-minute slot. So yeah.
I think you have more energy than most people, Dr. Thélin. All right.
And I don't drink coffee.
I do.
Dr. Thélin and Bailey, we have a number of comments in the chat thanking you for your presentation today. And I also want to thank you so very much for your practical and thoughtful discussion. And then now we have, we'll just share one last slide with everyone. We do have other educational resources here through Intera and on our website. And you will be able to see here in just a moment that you can connect through our website with your therapy consultant. And then also, if you scan this QR code, it will bring you to our Educational Resource Center, which is where we have recorded webinars and recorded sessions from other courses, and an e-learning module as well. So please feel free to scan that QR code and check out the Resource Center. And we will have future webinars as well, so stay tuned for those. And I think that is it.
And so I put my email in the chat, which we should have put on there originally, because again, like I said, you're building the network, and I have a lot of mentors and colleagues who are not in the same state, and I rely on them for ideas and complex cases to help.
Yes, well, thank you, Dr. Thélin, for sharing that. We will also we recorded this session. We will have it available on this Education Resource Center once it's approved, and we'll alert the attendees here that they can find that once it's ready. So again, thank you all. Thank you, Dr. Thélin and Bailey, and have a good evening. Until next time.
Thank you. Good night, everybody.